Yep. Okay. So we're recording, and I would like to hand over to Debbie to do this session.
Okay. Sorry, I keep flipping back and forth. Before we start, we'd like to acknowledge the traditional owners of the unceded land on which we work, learn, and live, the Wurundjeri and Bunurong peoples. I don't know if anyone's joining us from other parts of Australia.
No, I think we've got all Victorians.
Oh, we're all Victorians. Well,
Probably all in.
probably all in. Well, if you are joining from somewhere else in Australia, we want to acknowledge the traditional owners and custodians of those regions and pay our respects to elders past, present, and emerging. All right. Goals for today. We're going to define what an unintended consequences is, how they arise, which is numerous ways, strategies for identifying whether they're positive or negative. Because, sometimes they can be positive.
We don't get to see them.
You don't get to see it. No, that's true. And maybe potential research questions. The format today, I'm going to go through this paper on the left. Would that be the left? Yeah. Power, Paradox, and Pessimism on the Unintended Consequences of Digital Health Technologies in Primary Care. This is a great article. I'm going to summarize the article in this first section, but I recommend reading it. It is available through UniMelb Library. I think it's actually open access too. And then we're going to walk through the other paper, Unintended Consequences of Patient Online Access to Health Records. We're going to use that as kind of a case study. All right, so unintended consequences are those positive or negative effects that were not intended from the outset, but occur when adopting a new technology. And unintended is not the same as unanticipated or unexpected. So consequences can be anticipated and intended or unintended, but an unanticipated effect cannot be intended. Semantics here.
Yeah.
So not all consequences that are unexpected are unwelcome as well. So something good might happen that you did not think would happen or intend to happen, and that can sometimes be welcome. Usually though, it's the other way around. So when you're implementing a digital health technology, it really requires a shift in work processes and flows because you have to accommodate this new technology, and healthcare is very complex. There's a bunch of components that interact with each other in a nonlinear, dynamic, and unpredictable way. So you have actors in the healthcare system, and then the setting itself, and patients, everything. And so you have to make leaders and policymakers and people in, management positions, they have to make decisions within this complex situation and with a million competing demands. So all of this is to say is implementation is messy. Also, digital health technology can usually be looked to as an answer to difficult questions, which leads to maybe some over optimistic ideas, questions like how do we contain costs while maintaining safety and quality? I don't know, maybe a digital health tool could help us with that. How do we improve safety and quality while containing costs? Also a difficult question. Maybe a digital health technology could help, or making health services more accessible, or providing more timely patient-centered care with limited resources. So these questions are just kind of to get at how healthcare has a lot of difficult issues facing it, and digital health technologies should not necessarily be the first thing you use to answer that, I guess. Sometimes it's low tech solutions or no tech solutions, but complexity is often overlooked. So think about the complexity. Okay, before I get into those, so this is from that first paper, the Power, Paradox, and Pessimism paper. The paper goes on to describe different types of consequences, so unintended consequences, that they've found in searching the literature and just kind of their own experience. And so I wanted to just briefly summarize these because I think they're really interesting. So you have consequences that disrupt power relations. These are patient-provider relationship, interprofessional power dynamics, patient demand, or balancing power. And so the patient-provider relationship is when you have that shift in dynamics when patients have more knowledge. This was in the paper, they provide the example of patients coming to their GP with a new app and saying, hey, look, I have this new app. It helps me manage my diabetes. And the GP doesn't know about the app. So in some ways, it's kind of shifting the power dynamic away from the provider, which depending on your perspective might be negative or positive. And then there's interprofessional power dynamics. So this happens a lot where a decision maker adopts something like video consultations without consulting providers. And so then you have providers feeling like they don't have any say and they feel low power compared to executives who are making these decisions. I think that one is more from the clinician point of view, but it's something to think about when you're implementing in the healthcare setting. Even if something you're doing maybe has some buy-in, you got to think about everybody who has buy-in. And then there's patient demand, so increased pressures for treatments. It says scant evidence of this because they do mention in the paper there's not a ton of evidence for this. The example they brought up was e-consultations, increasing antibiotic prescribing. And this is something I think is being tackled more recently, but the example is when you have patients that are, they don't feel well, they have an e-consult with their provider and their provider gives them antibiotics for, their cold, their sore throat. That's probably a viral infection, so antibiotics isn't going to help. But the patient wants something because they're in pain and they want something to feel like they're getting treatment. I feel like now with antibiotics prescribing though, that's something that has been, I don't know, at least in the United States, I feel like it's a thing that has been, people are talking about it more. I don't know if that's the case.
In terms of resistance, like overprescribing.
Yeah, overprescribing. I feel like that's kind of, and then balancing power. So this is about patient empowerment and the ability to monitor, address issues that matter to them. And again, this is using apps, having reminders to take meds. So the idea is patients are empowered to kind of help manage chronic conditions. And then we have consequences that contribute to paradoxical outcomes. This is, I think, what people think of when they think of unintended consequences, is these effects that are opposite of what was intended. And the example they bring up are the ironies of automation. So often when you implement more advanced technology, it requires an advanced skill set. A good example of this is using AI in radiology. Having an AI read the image and analyze it, it requires people to have at least some baseline level knowledge and competency to know what the AI is doing. Well, ideally you would. I don't know though, maybe people are using it without knowing what it is. Tools to designed to manage workload can often increase workload. Safety initiatives that are used to correct some medical errors, for example, might produce different types of errors. One of these they brought up were interoperability. So sharing information, but sometimes that can lead to incomplete information, or clinical decision support systems, which can lead to information overload. So maybe when there's too much information, it makes it harder to actually make a decision. And then there's innovative communications, so worse interactions. This would be seen more in, for example, if you're having telehealth and there's technical problems, you're having the provider and patient are not able to communicate as well, or it might delay care. When telehealth, the promise is that it's more connected and you can see a provider. So it's kind of the opposite. We're creating that worse interaction. And then the last one, I think this is the last one, are consequences that result in corrosive pessimism about digital health. And I don't know, you maybe have run into this in your own workplace or at your GP, I don't know, where you have a provider that has a really negative experience with a digital health technology. So then they're a bit resistant and skeptical about it. And it talks about this shared narrative of failure, poor value for money, and compromised safety. So the burden of technology, where they feel like the care is less personal and interferes with the patient-provider relationship. And this is something, the burden of technology and this relationship thing, this is seen a lot when you look at the literature from when EMRs started getting implemented. A lot of providers were like, I don't want to use this. I don't want to have to get on here. It's going to interfere with my patient care. It's just burdensome. Like that happened a lot. And now I feel like a lot of providers like EMR, but I don't know. The feeling of powerless and lack of control when implementing digital health technologies. And that again kind of stems from when there's not that buy-in. So decisions made higher up without buy-in from the people that are using the technology, it contributes to that powerlessness and lack of control. And it's just, if they had just consulted and gotten buy-in before making the decision, I think that would have helped, but people don't think about that. There's consequences that require workarounds to avoid cumbersome procedures or minimize interaction with new technology. So if a provider is presented with, hey, we want you to use this app with your patient, but they don't like using the app, so they may just end up working around it to avoid using it, which we hope they don't do, but you just never know. Or if there's like, okay, we implemented this checklist in the EMR, but they don't really like using the checklist, so they're going to do everything they can to avoid using it, even if it means more work for them. And then there's skepticism about the competence and security. So if they don't think it's secure, or they think, okay, this isn't a really well, I don't like this app, or I don't like the way this was made, they might be skeptical about it. All very interesting stuff. So just a conceptual review. I think what we're getting at with this is you have to move beyond the view of barriers and facilitators and kind of look at their strengths and limitations, because every digital health technology has strengths and limitations. And I think there tends to be this overly optimistic view of, oh, well, we'll look at the barriers and facilitators to implementing this without acknowledging that there's limitations of the technology itself, and not confronting those limitations can contribute to these unintended consequences. And then the dominant health policy discourse, tends to be uncritically positive. So I really like this paper because they said you need to think about who becomes empowered at whose expense and with what results. So when you're thinking about your digital health technology, who is being empowered by it and at whose expense and what will result from that? I think that's an important kind of takeaway from this paper. Okay, we're gonna go to a case study, which is the other paper. But before I do, are there any questions or comments? If anyone has, you can pop them in the chat or unmute yourself. Okay, I'll assume this is perfect, just kidding. Again, I recommend reading the paper. It is a really good paper. I remember when I found it, I couldn't put it down. I was like, this is exactly what I've been thinking. Okay, so this case study, we're gonna look at unintended consequences of patient online access to health records. And this was a qualitative study in the United Kingdom in primary care settings. Andrew Turner, the lead author of this, they published a second paper that was the unintended consequences of, what was it? They have a second paper that's looking at another technology. And I'm sorry, I can't think of it off the top of my head, but a really good set of studies here. Okay, so the background on this study is, a lot of healthcare systems in a lot of countries are trying to make medical records accessible to patients in some form. An online patient access satisfies that moral argument that information belongs to the patient and should be accessible. And online access is intended to enable patients to take greater control of their health, in parallel with increasing the efficiency of care and, reducing GP practice workload. And so this would be, you maybe have seen them, there's patient portals where you can log in online and you can, book appointments, look at your notes from your, visits, whatnot. Some GPs use like a mobile app to do this. I know Royal Women's, they have a patient portal you can log into, the Health Hub, I believe, and you can see, and that's an Epic portal. So research has found that online access can improve health outcomes and patient safety, and patients have used it to understand and control their health. And it can be good because you can correct errors. So if you go on and look at your notes, you can see if the provider, maybe they didn't understand what you were telling them or they wrote something down wrong. You can correct errors or prepare for future appointments. Hey, at my last appointment, we discussed this. I'd like to talk about, this next thing, whatever. So the aims of this study were to identify and understand the unintended consequences of online access to health records experienced by patients and practices. And the goal is to inform guidance on mitigation of consequences, but more at the practice and policy levels. So they did semi-structured interviews with patients and staff from GP practices. This was part of a larger study. And they did the interviews in April 2020 when offering full record access to existing patients was not necessarily obligated. So it was kind of an option that was starting to be rolled out. So they defined unintended consequences by contrasting it with NHS policy documents that outlined the intended consequences of providing online access, which I think is I really like that they did this. So they went and looked at policy and said, when we implemented this policy of providing online access, what did they intend for it to do? And they found kind of two main areas. It was intended to enable patients to take greater control of their health. So providing info about their conditions and history to support more personalized care. Well-being and independence, helping patients manage their own health, enabling more informed decisions and involvement in decisions. The second area was to improve the efficiency of care or improve practice workload. So this was to create increases in productivity that would outweigh the initial investment through reductions in ad hoc contacts with patients, meaning patients could just go look at the online record instead of calling the office to be like, hey, can I see my lab results? And then enabling care to be designed and delivered in a place that is most appropriate. So those are the intended consequences. And I tried to color code these so that we can keep these separate. So in the results, these are the practices. They range from small to large, mostly urban. There's a couple rural ones. And then you can see that they interviewed a few staff of them. Not all of them got patient and staff though. And then those are the patient characteristics on the right side. I didn't realize it was mostly female patients. Not that that matters, but it was evenly split on male and female GPs at least. All right, so for the intended consequence, enable patients to take greater control of the health. Unintended, patients describe discovering information in their health records that surprise and distress them, which the original consultation didn't prepare them for. And then, oops, not GPs and admin had little awareness of whether patients experience this, even though they did have concern that it could cause distress. So basically, the GPs and admin before this rolled out were like, we think that if patients have access to this, it's going to distress them. But they weren't really aware of it actually happening. And I pulled out a quote. This is from patient 1 at practice 2. It says, I went into my patient record to look for if any of the blood test results had come back. And it said, urgent referral request, suspected breast cancer. You're instantly like, Christ, the doctor thinks I've got breast cancer. So like, wow, that's so scary. And we'll have discussion at the end because I'm curious how many of us have actually experienced that. I know I have. The next one are intended consequence to enable patients to take greater control of their health. So the unintended consequences, they found that access to information didn't actually equate to greater involvement or better management. And the information in the record was not really tailored to the needs of the patients. So it led to misunderstandings and misinterpretations, meaning the information in the record was put in there by providers, but they weren't really putting it in there like based on what the patient would be able to understand. It was just kind of like, well, these are my notes. And then GPs were concerned about how information might be interpreted by the patients. And so they started being more transparent about the consultation notes, explaining to patients what they were putting in their notes, which I would argue is kind of a positive unintended consequence. It made GPs more aware of how this information may be looked at by patients, so they involved them more in writing it. And we'll have discussion in the end, but I've definitely been in appointments where a doctor has been like, I'm gonna put this in your medical record. Is that okay? How would you like me to word it? And I was like, what? I've never been asked that. But I think part of that is this fear of misinterpretation by patients. Oh, and then the quote on this, should I read it? Okay. Yeah. There were 2 or 3 things that the patient had to remember following the consultation. And so for me, it's always been natural. Just go online and check so you can remind yourself. And she was like, oh, I don't really look at my records anymore. And I said, why not? And she said, well, because I don't want to. I'm scared of seeing something that means I've got another problem on top. So I was a GP at practicing. So he's saying, you know, patients kind of stop checking out of fear. And so I think being transparent with the notes could help with that, saying, hey, this is what I'm going to put in your record. You don't need to get worried about this. This is just a normal thing. Like, I think, I don't know, it's an interesting unintended consequence. Okay, the other one, improve the efficiency of care or improve practice load. So the unintended consequences, staff found that when they had to prepare records before giving patient access, it added to their workloads. Like they had to redact sensitive information. And when they say redact sensitive information, I'll read the quote here, but it was more to help patients who had other people who had access to it. And the quote kind of gets to it. It did increase workload for patient education. So GPs had to have face-to-face for some patients to go through the online record together. And that is a really interesting point for digital literacy and digital readiness. You know, having to do face-to-face with patients to go through it, that's a lot of time and effort. And I think that's something that could have been maybe not prevented, but if they had actually kind of assessed the digital literacy of their patients beforehand, they could have maybe arranged like education sessions with, you know, so that they could have like a group of people there instead of doing one-on-one. And then there was additional workload to manage access to records for teenagers. So redact comments in the child's record that the patients don't want the child to see, or vice versa, or allowing access for parents who have separated. That's something I didn't even think about, but if you had a child who didn't want their parent to see something, that's pretty serious, you know, and that required additional work to manage that. So the quote on this one, there have been a couple of occasions that's actually been really quite difficult, where the kids find themselves in a difficult position of parents saying, well, why can't I have access to the notes? And you say, well, it's set up for your child to say whether you have this or not. And the parents will say, well, they don't mind. That will be fine. Of course it will. And the child is there and you can see the child squirming. If you know the situation, you can actually engineer a way out of it. But sometimes that can be quite noisy and quite difficult. That's GP1 from practice 2. And that's a pretty serious consequence. And that's something where perhaps before rolling this out, if they had done a little bit of investigating on, okay, how do we handle these situations? Because it seems like it got rolled out without having like a policy or procedure in place for handling these situations. Because in something like this, if I were the GP, I would say, oh, well, we have a policy that we can't do this. And if you can, you know, state something kind of authoritative, that could maybe help. I don't know. Okay, I think this is the last one. Let me check. Yeah. So the last intended one, improve the efficiency of care or improve practice workload. Oh, this is the same intended consequence. This had a lot of unintended. So there was risk around online access for patients experiencing domestic violence and abuse, and the difficulty of ensuring that access would not cause harm if the perpetrator viewed their record. This is definitely a serious issue. And again, it required more work to minimize harm. And I think this is again something where if you had looked in and done a little bit of groundwork beforehand, you could put policies in place and procedures so that all providers could understand and work through this. And then the managing and monitoring queries from patients, challenging information or finding errors that required correction. You know, patients disagreeing with appropriate codes generated more work in the way of having to educate the patient, having to review the codes, having to review what was diagnosed, and etc. And then they found patient uptake of using online access was pretty low. So the quote on this one, domestic violence and abuse is one of the reasons why the process to get access is a bit more long-winded now. A consultation in advance allows the GP to speak to the patient, and that's kind of why we want the face-to-face, because they can be alone in the room. The GP just needs to make sure that they actually want the access themselves and it's for them. So it's kind of that first point. Yeah, it's a difficult situation. And something I didn't even think about until I read this paper. It's like, oh, wow, okay, that's serious. So this is just from the discussion. The implementation of online access is more complex than the intended consequences would suggest. Online access generated unintended consequences that negatively impact patients' control over and understanding of their health. All right, so this is discussion time. All of us get our discussion hats on. I have 3 main questions. I'm gonna start with this first one. Have you personally ever experienced unintended consequences from using a digital health product? And that could be a patient portal, mobile app, your Apple Watch, you know, telling you. And I'll give an example. I have definitely been that patient where a doctor's like, we're gonna take your blood test and we're gonna put your results online and you can view them. And then when I went and looked at it, this was at Utah, they would put your lab results online and it would put whether it was too high or low relative to the range. And so I remember looking at my blood results and a bunch of them were like really high and low out of range. I was like, oh my God, my blood is all out of whack. And The provider was like, oh, those reference ranges are out of date. Everything looks normal. You're fine. But I was like totally freaked out. I remember like messaging them and being like, am I okay? Do I need to come follow up? And it was just like, no, you're fine. These are old values. We just haven't updated them. And it's like, well, you need to update these. And so it's, you know, patient portals. I mean, I was exactly what they said they don't want to happen. But I don't know, if you have an example though, you can unmute and talk, or you can put it in the chat if you don't want to talk. You also don't have to share. We have other discussion questions.
This isn't my personal experience, but I've had an experience. A patient explained to me what he'd discovered on his patient portal. He'd gone in for really minor surgery, and he then had access to his operative note written by the surgeon, which is pretty clinical. And I think at the end of the document, maybe there was a phrase from the anaesthetist saying, oh, he's fit to undergo a cystectomy, which is bladder removal. And he'd never had conversations with any of the team that that was a possibility. And that appeared in his notes. All of a sudden, he's thinking he has to have this surgery. And in the end, I don't think he did. It was just they were remarking that if he needed to, he would be well enough to undergo that.
Oh, wow, that's pretty serious. I would be devastated.
Yeah, and I think the people who were writing those notes wouldn't have even been aware that it was visible to the patient on the cub.
Yeah, that's a good point.
There was, yeah, I think that's coming off that example was another one where there was again a patient kind of late teens, but under a lot of care of parents because they were mentally unwell. And while the parents thought that it was quite it had quite a mental illness framework, there was a lot of underlying substance use and abuse that they weren't aware of, but they had to go interstate for travel, so they weren't able to provide care for their son directly. And their son, the treating physician was like, you know, your parents are away, do you wish for them to have access? And he was like, well, yes, because they need to know these things. They're my primary carers because they otherwise support me. But it seemed like an absolute bombshell was dropped when the parents got access to his chart, not realizing all of this underlying substance abuse or you know, use thereof. So it opened up this whole again, completely unintended, and they were interstate as well, so there was no chance of them kind of connecting. And this was a person who was, you know, in quite high acuity care for mental illness. So it was just a bit of a ramification that they weren't expecting, because it was with good intention that they could access it, so they could help see how he was you know, being cared for whilst being hospitalized, and they weren't close by. But
oh my gosh, yeah, that would be devastating.
was another example of just again, I think that digital and digital literacy has a really strong need in the population, and there's an assumption that everybody with digital devices for otherwise personal use must be at some level of transference, but we definitely know that that's not the case.
Yeah, agree. I think it's like, you have a smartphone in your pocket, you know how to use this. It's like, well, no, I have trouble with Excel sheets. I don't know. Anyone else have something they'd want to share?
Hannah, you go.
Just important that people have the opportunity to get their results from their doctor first. So I guess, you know, on my health record it's all right, because I understand what a blood result might mean, but I've had friends go on and again, like, it seems really out of range, and then they Google it and then have a big freak out, and it might be a couple of weeks before they can get into the doctor, when it may have actually just been something very simple, and then suddenly they're thinking they've got cancer or something like that. But I've also got a story where a patient used it actually really to their benefit. So they had an operation which came back with a result that was unexpected, and it was missed by the surgical team. And they were reading through my health record and then brought it up with our team. And then we were obviously able to apologise and follow it up. So I guess that's a good unintended consequence.
Yeah, the positive ones happen.
Yeah. And Carolyn, sorry.
I was just going to say, I've got a couple of friends with type 1 diabetes, and some of the apps that they have to monitor sugar levels and insulin and all of that type of stuff. It's been like, I think being able to use the apps has been really amazing, but the unintended consequence is it's created, I think, a level of anxiety, especially if their control isn't perfect, and especially if it's, color coded. Oh, I'm in the red zone, I'm not doing very well, it's all my fault, etc., etc. And yeah, I think that's a not uncommon thing that some people with type 1 diabetes do go through with those apps.
Yeah, it's definitely those apps that are supposed to help you manage a condition end up causing so much distress. I don't know. It's almost like, okay, the stress versus management.
Well, there's a shift in the access to information as well. So whereas you may have had a weekly checkup or a daily checkup, depending on how you were going through various phases of the illness, to then having that daily update of information, that can be quite triggering, but that they might not be prepared for.
Yeah, so I'm sure on a daily basis there's that natural fluctuation.
Yes.
And now you're just catching those instead of an overall trend. Scary. Anyone else? Is there anything in the chat? I'll move on to the next question. All right. Thinking about your current, past, or future digital health projects, do you foresee any potential unintended consequences? These can be negative or positive. And I want you to think about your target population, contextual factors, workload, workflow processes, patient distress, physician distrust, distrust. Thinking more broadly about some of the consequences we talked about, like those patient provider interactions, interprofessional interactions. Yeah, and you can pop stuff in the chat as well.
Sally here. I think even though we have good digital systems which provide a lot of information, there is still an inherent distrust with some clinicians to believe what other clinicians have written, and so they still go and ask the patient, and the patient sort of goes, well, I've already told this story 5 times, why am I telling it again? It's sort of negating what you would see as a positive of having a digital system, allowing a variety of different clinical staff to see it. The clinicians just haven't quite got to that where they think the other person's history taking and recording is as good as theirs. They're worried in case they miss something. So I think there's always that sort of negligence factor there as well.
Yeah, it's a very good point.
And workflow as well. I mean, I know that with a lot of projects being on in the past, you've got to dig so deep and find the right people to ask to get those workflows, because there's always bypass systems. There'll be one person and they'll be doing something, and then they won't be there the day you're doing the workflows, and then you build it all into your digital system, and then it goes live, and then you find out that you missed a crucial part. So how you overcome that, I don't know. Engagement from the bottom upwards, and obviously selling or trying to persuade them that I think people seem to think the digital systems are just going to save them time and save them effort, and that's not the case at all. The premise, of what a digital system is about is more about, if we can, is about patient safety and visibility of documentation and retrieval of documentation, as opposed to time saving and things being easier, and recognition that a system cannot work like a human brain. Whereas, it can't, it's sequential. It doesn't multitask like we can multitask in the same way. Recognition of that.
I think absolutely. And further to your point about the workflow processes of how it is inevitable, and that there's this expectation of streamlining and efficiency, and that sometimes positive. So in doing those workflow mapping to try and for CDS or something, and then you're finding that there are these workarounds that have been there for so long, which then provide another root cause below it, which sometimes the discovery of that can be seen as really favourable, because it then allows an exposure of something that was completely unbeknownst to other operating levels but contributing heavily. But it's also not often seen favourable because it's another issue to solve, but it wouldn't have been solved if it had come through this process of going through and analysing the workflows.
Yeah, that's a
Good point, Sally.
Yeah, that's a good point. I was listening to a presentation last night for the AI conference.
Oh yes, yep.
And she mentioned that you have to have AI and the human, because it's like the human can work better with AI, or theoretically, but that's the same for AI. AI doesn't work better without the human. You need the human, you need the provider and clinician there. It's a package deal. You can't just have AI take over and do everything. So
it definitely augments performance to deliver a high quality of care,
yeah.
knowing that we ebb and flow with our energy and ability to process complex decisions on a daily basis. We're definitely not that optimal performance.
Yeah. Anyone else? I have one more discussion question. Oh yeah, so what strategies could you use to mitigate potential unintended consequences? This is assuming they're negative. Although if you had a positive unintended consequence, I would think about strategies you could use to kind of leverage or optimize those. I put a few examples, like doing service design, doing a simulation study, co-design with patients. It's like what Sally was saying with when you go to talk to providers and maybe a person isn't there that day. That's something where when you're doing co-design, you probably should have more than one session, have multiple sessions, making sure you're getting all of those stakeholders, so that you're not missing someone who just happens to be gone that one time you did it, yeah.
The other thing is they've got to be feel safe and comfortable to contribute to it as well. And I think that, if you have people in the room and they've got their managers there, they're much less likely to say something that maybe they perceive that, it works well for them, but it's not the right way to do it. And the other thing is they may be getting pressure from other people. I remember working on a workflow design for potentially going with electronic radiology requests. This is years and years ago, and discovering that they ran on a dot system, a different coloured dot system that one particular admin person did, and it was almost like a secret code, and she had certain consultants that would come in and sort of pressure her very subtly to get their patients in ASAP. So she would use the color coding inappropriately at times, I suppose. So I think to be able, we were lucky to wheedle out that information and to be able to get it. We made sure that they didn't feel threatened. But I mean that's often the case, is they don't. You kind of have to really get them to describe their day-to-day work, and there'll be a lot of chaff in there, but there'll be some real bits of corn that you want to pull out and that's useful.
Yeah.
And Hannah, maybe to your previous comment, to the previous discussion, have you, considering your awareness, are there a couple of thoughts that are coming to mind as to how you might be able to navigate this?
Yeah, I guess in relation to what Meg's saying, in my project, I'm quite aware that my project may increase the divide between sort of socioeconomic and language background. I guess in the pilot phase, it is a little bit harder to address, but we're hoping that when we do a broader implementation, we can address some of the language things in terms of having it translated into common languages we encounter. But one of the things I still realise is, so we're looking at an app to use at home to help with self-monitoring, and a big part of it is it will direct them to call various service providers. And even if it tells them that in their language, then they're ringing a service provider that speaks English. So I think that's a challenge to address. We've also spoken to some of our culturally and linguistically diverse staff, which has been really helpful, and hope to get some feedback from patients. But yeah, I think it's one of the things to keep thinking about.
Yeah.
I have a question just to the wow.
I don't know why that would be.
To everyone who's on today, and if you're undertaking projects or have done projects in the past, have you found yourself listing intended or unintended consequences? Have you found yourself doing an activity to determine whether or not you've thought through all the unknowns? And just feel free to pop your hand up if you have, or come off mute if you have comments.
I think sometimes they come up and you sort of identify them on the risk register as much as anything. You go, oh, didn't expect that. Let's put that on the risk register, and then until you've got a way of mitigating it, or at least, you know, getting it out there and deciding how to best manage it.
Yeah, voiced from a lot of experience there, Sally, I think, in terms of that regular use of risk registries and associations. So that's sometimes where I guess the unintended consequences pop up. Sometimes they probably don't seem like the level of severity that would reach a risk matrix. But if they're in there, they're in there. So.
That's a good point.
Moving forward, I think also I'll build from that question while everybody's having a bit of a think. Moving forward, will you have a look at all of your project goals or intentions and potentially think about whether or not there are some unintended consequences and against?
I think for me, certainly thinking about things in terms of a learning health system this year has been really helpful. And then also being able to workshop our projects in the SIG from other people who are more experienced in terms of these sorts of projects has helped me think through some of the potential unintended consequences. I'm sure there'll be more, but I think, yeah, just having this and sessions like this help put it in front of mind and the importance.
Yeah, you're right. It does come out through the shared learnings more so because quite often they're not published.
Yeah, a lot of
like
them
this
are
is
not
we're coming back
published.
to the full circle, but it's
Yeah.
not published.
Well, and usually if it's published, it's at the very end, you know,
Yeah.
a sentence or two, like, by the way, we saw this, but, you know,
It's too late. It's another thing for somebody else to worry about.
yeah, it's someone else's problem. But that's you know, maybe that's something for next year. We can think about how to bring something like this up sooner, or in that development phase of thinking about what you intend and how unintended things could happen. I think the case study looking at the policy intentions, you know, your definition of what your intended consequences are will depend on your digital health product. And I think going to those policies and procedures and then, or how you define it, like what do you intend, is a good way to start thinking through those. And relying on people that have more experience, because you cannot always rely on that published research.
I think that's where Sally lends a lot of insight too.
Yeah.
I think in any project, one of the things when particularly you've got a large range of people, including patients or other outside of the hospital people, is to have is to have a common language dictionary. So we're actually understanding what it is we're talking about, because people do refer to things in different ways, and there can be some mix-ups from the very beginning.
Yeah,
That's
100%.
That's another really good point.
Yeah, like Common Language Dictionary is a great example.
Yeah. Any other points?
I was going to say my only other takeaway has been looking at some mixed methods research or evaluation. I think at least I came from a background very much into the quantitative outcomes of a project. Whereas I think this has helped me to think a bit more about some of the qualitative aspects and how that can strengthen the design in terms of understanding both intended and unintended consequences.
Yeah, that's a great, including those interviews or just focus groups or discussions with the users is a great way to get ideas of what's actually happening. And making sure that you talk to them in a space where they feel like they can tell you what's going on. All right. Thank you. That's all I have.
Sorry, I forgot about the last slide.
What?